is really a facilitated discussion. So we expect a lot of questions from all of you in the audience on more of the why and the how and the what that's available in health wearables and where we're going with this. We've had a number of other distinguished speakers here join Peter to talk about this topic, and I'll introduce them one at a time, let them tell you a little bit about their background, so you get a sense for their own interests and where they are and what they're working on in this field, and then we'll open it up for questions here. So our first one, Dr. Ciro Cattuto, who you heard earlier, is the Scientific Director and Data Science Laboratory Head of the ISI Foundation, a 30-year-old research institution that tackles fundamental and applied challenges in complex system science, network science, and data-intensive mathematical modeling. He's a founder and PI of the Socio-Patterns Collaboration, which uses wearable proximity sensors to measure high-resolution social networks and to develop analytics on top of human proximity data. He's interested in the impact of data science on healthcare epidemiology and public health, and is a member of the WHO Collaborating Center on Complexity Science for Health Systems.
Good morning. How do you want to run this? Do you want us to go through? Yeah, sure. Sure. I would say that we got a great start on the role of sensors from the point of view of extracting data points from individuals. So this is somehow, if you're doing epidemiology, this is sort of a host-based perspective where you focus on one individual at a time, and then you aggregate this at the population level to get signals at the population level. And these two perspectives, which imbue both the research and the applications, are somehow exhibit a gap. There is the individual perspective and there is the population perspective. A lot of the work we've been doing recently using sensors is focused in the mesoscale domain. It's focused in domains where, such as a hospital or such as a healthcare unit, where you wanna mine data about interaction patterns, correlated activity patterns, workflow metrics, team dynamics. So somehow it sits between the individual perspective and the community perspective. And I believe that there is a lot of space in extracting new types of signal, especially for outcome-based institutions such as healthcare institutions, delivery, hospitals, in extracting new types of signals that quantify KPIs about processes, about workflows. So it's not really about the individual outcomes of persons. It's not really about population health. There is an entire new domain which is opening up where you're using Internet of Things technology to extract complex signals at the mesoscale, and this is what informs a lot of our recent activity in this direction.
Thank you. And I'm going in alphabetical order in case you can't tell. So now I'll introduce myself, Casey Decker, and I'm a senior associate with Booz Allen Hamilton, as well as an affiliate faculty with Emory University Rollins School of Public Health and Health Informatics. And I work a lot on projects involving wearable technologies right now, one called Apollo that we're working on to be able to really develop the analytics from groups like Validic from the individual wearable technologies across the hundreds of different ones that Peter mentioned that are already out there, plus the ones coming, to be able to use at a healthcare provider level and to be able to do that aggregate analysis of the data there. Our next speaker here, Dr. Jared Hawkins, Research Associate, Boston Children's Hospital and Harvard Medical School. Jared is a research associate jointly appointed at Boston Children's Hospital and Harvard Medical School. He received his PhD in immunology from Tufts Medical School and an MMSc in biomedical informatics as part of the National Library of Medicine training program at Harvard Medical School. Jared is passionate about using healthcare data to improve the quality of patient care, better understand population health, and influence policy through education.
Thank you. Good morning, everyone. I work in a variety of areas in biosurveillance, population health. I think most relevant to this panel is a project we have with a wearable sensor for measuring continuous body temperature. So it's called the iThermometer. And what my focus is on is doing something actionable with this data. So we are collecting the temperature data and then trying to address different issues. So we focus both on the consumer, directly to consumers, on clinical aspects, and on population health. So for consumers, we're trying to take in this information feed it so temperature data and contextual symptoms, and feed that data into a decision support framework and provide educational information back to consumers. So taking information, kind of the something for something economy, and providing back educational information that will be useful for consumers. On the clinical side, we're taking in this information, temperature data, and feeding it directly into, so taking it from patients and feeding it into clinicians. So multiple clinical trials underway right now trying to monitor temperature in sensitive patient populations. And then finally, on the population health side, there's obviously a good need or good use for using this data for larger biosurveillance. So syndromic surveillance as well as surveillance in outbreak scenarios such as Ebola symptom monitoring.
Thank you. You've all met Peter. I'm going to just skip introductions on Peter. We've all gone through that before, and go to Dr. Elad Yomtov. He's a senior researcher at Microsoft Research. Before joining Microsoft, he was with Yahoo Research, IBM Research, and Rafael. Dr. Yomtov studied at Tel Aviv University and the Technion, Israel. He has published 3 books, over 70 papers, of which 3 were awarded prizes, and filed more than 30 patents, 16 of which have been granted so far. His primary research interests are in mining internet behavioral data to improve health and medicine. He's a senior member of IEEE and held the title of Master Inventor while at IBM.
So as Peter said, most people, when they have a medical concern, go online to search for it. So that's where we started. And I think over the years, we've kind of understood where we can provide information that's hard to get in more traditional ways. And that's where we've been working. So for example, we can make associations where people find it difficult to do so. And so we can find new adverse reactions of drugs that take a long time to appear simply because we can make the association for people where they cannot. Another area that we've worked in is using these kinds of very large data, query logs, so search engine logs, Twitter data, Flickr, what have you, to learn about more, I would say, intricate things related to epidemiology, to see, for example, how infectious is influenza at any given moment. And influenza is a good example because that's a disease where most people will never get to see a doctor, but they may ask about it on the web. And that's why we have so much data that we can use for that. And more recently, I've been dabbling in the opposite extreme, which is very small data. And we've been experimenting with learning which kind of feedback we should provide people in order to get them to exercise more or to reach their health goals by automatic learning, which is something that can scale for a very large population without actually having to have a human intervention in the middle.
All right, thank you. So we will go ahead and open it up for questions from the audience here. As facilitator, I've got a number of questions already set. I'll go ahead and start with one of those, but we want to get questions from the room. So please, there's a microphone, it looks like right in the middle there. If you'll step up to that to ask your questions, we'll go ahead and get started with the panel here. So the first one that I wanted to put to the group here as we get some folks up in line here is really to tie this into digital disease detection, where we're going the rest of the day. How can wearables radically change and improve the current digital disease detection practices? So what are some of the specifics that you see already occurring or will be occurring that will radically change what's going on today?
So, as you all know by now, we have been collecting data for close to 3 years now, and we actually see very early disease detection possibilities. And what we are looking at in the background, which we don't publish, is, are people are they on their way to get diabetes 2, for instance, which will create a lot of cost. And so it's not, diabetes 2 is very seldom a single disease. There are follow-on issues, the hips break down, heart attacks, etc. So this we track very carefully. So in our system today, we're really trying to find this behavioral pattern early on for very large employers. So we now have employers who have 500,000 employees. And it's very important that you see what kind of diseases do they get within the organization, and that you set an early warning sign. So we believe with digital sensors that you can predict. We also track cancer just to learn. And it's actually pretty scary. Heart attacks, cancer, diabetes too. We feel today that our data is good enough with between 90 to 90%, 95% detection chances of if you continue living like this, we can pretty much calculate that you will have a 95% chance of getting a heart attack over the next 2 years. So it really is predictive data.
Yeah, I think on the individual level, it's really about using wearables to collect data and then getting a baseline for an individual. So it's really establishing that baseline and then looking for any kind of deviation that might be an aberration. So I think on an individual level, there might be, or on, between different individuals, there might be a lot of differences in whatever metric you're looking at. But when you really establish that baseline, you can have that early detection that something might be wrong. So I think that's a really nice area that this type of data provides for.
Yeah, so the individual level is definitely something that looking at the normal and then finding deviations is very interesting, and there's a lot of work doing that. On the population level, I think those diseases that sort of surf under the radar of health authorities are where wearables will have a very big effect. So if you think about the opposite extreme, I think something like Ebola is probably not a good example, but influenza very much is, and there these kinds of wearables or whatever you do on your cell phone is something that we can provide real benefit to the health authorities.
I'm moving a bit to the scale of an hospital, for example. We've been using, as some of you know, like wearable sensors in hospitals to track interactions between individuals, spaces, objects. So in an Internet of Things scenario, all of this data, which today are really not used, or the interaction data between the individuals, I think will unlock new types of metrics really to quantify outcomes and relate outcomes to the complex processes that need to happen in a healthcare environment in order to manage specific conditions. So this requires really zooming out for the individual and starting measuring a number of interactions between individual places, objects that do inform and do condition the outcomes, and today are not quantified. So we see wearables as just one component in this type of vision, which enables to mine interaction data, process, and define new type of KPIs, new type of collective metrics, of team-based metrics, or process-level metrics.
Thank you. So I see Clark is at the microphone here. Do you have a question? I don't think the microphone's on yet. Clark, do you want to come up here while they're getting it figured out?
I'm Clark Freifeld from HealthMap. So you can't change what you can't measure is the expression, and I think that applies obviously to wearables, also probably would apply across the whole conference. But there's a problem, which is that about half of Fitbit users abandon their device after 6 months. Fitbit has sold 21 million devices. They have 9 million users. So how do you get people to stick with these wearables, these different trackers, this whole kind of health monitoring process?
That's a very good question. I think, and I have nothing against Fitbit, and they are a part of ours. I think what happens with a Fitbit is you get excited when you buy it, you wear it, and the first month or two, you see how many steps do I walk. And then you know I walk the 4,700 steps a day, and then most consumers say, and so what? And then, you know, they either put it in the washing machine, which happened to my Fitbit, or they, you know, stop wearing it. So I think it comes back to the context of your life. So what we did at Cattuto was we did exactly the same experience. You know, we were tracking people, and what we invented, so the health score is patented, and we also invented something that we call the feedback loop. So the feedback loop uses artificial intelligence that analyzes your life in real time. And the feedback loop then streams in, you know, notifications around your life. And they can be many different areas. So basically, we use light artificial intelligence, adaptive math. So we kind of create real-time statistics around your life. And then we feed back into your life around your mental well-being, about your movements, about your nutritional behavior. And this can be, I'm just making up as we go, it could be like, you know, that we asked you one week, what kind of meat do you like? And then the person writes back, raw meat. So then, of course, we try to, you know, get this person eating maybe a little bit of fish, salad, etc. So we have all these artificial rules programmed into the system. That's point number one. Point number two is what we have seen is that if you start understanding people's life, and that was why I made the foil one size fit all, does not work at all. Fitbit assumes that everybody is interested in their steps. But steps is one data point, like you said before, out of 500 data points around your life. So make it relevant, figure out people's life, and then start feeding back into their life.
Yeah, I think I totally agree with that. I think you really need to incentivize users rather than just collecting the data and displaying it. That's not really enough after the first week or the first few days. So it's about returning something meaningful to them, whether that's a health score or in our case with the temperature data for, let's say, for parents with a sick child, we're returning back information that's relevant to them, what the symptoms might mean, and when you might want to talk to your doctor, and kind of a peace of mind. So it's doing something with the data that you're collecting, and I think that is important, especially to get past that first novelty hurdle after the first few days.
Yeah, so I think the one size doesn't fit all is very true. And I mentioned this experiment that we're having now, trying to learn what information we should give people to get them to exercise more. That's with an older group of diabetes patients. And in fact, we opted not to use something like a Fitbit, but only to use their cell phone for monitoring their activity. And the reason is that they really want to forget about their condition. And so if you give them a Fitbit, within a week or two, they will forget to charge it, and that will be the end of it. But nobody forgets to charge their cell phones, right? So I think that's one aspect of it, trying to figure out what people are willing to live with and go for that, even if it's not perfect. And the other part, which may be going against the grain of this panel, is I'm quite happy if we get people after a few months to change their lifestyle so that they do walk more. I'm quite happy that they stopped using our system. As long as we taught them how to maintain a healthier lifestyle, I'm happy with that. And perhaps that's quite enough if that's all we can do.
Yeah, another important point I think is that just like one size fits all healthcare is really an obstacle, the idea of a one size fits all engagement strategy is also a challenge. It's also very hard to land on the reality of things. And here I think we need to learn a lesson from the web community, for example, where like query logs and complex behaviors have been mined in order to infer psychometric profiles that then you use to engage the user in a targeted fashion. So I think we'll need more algorithmic targeting. I think we'll need more technologies that were developed in the context of web query mining. And already health insurances are actually moving quite fast in using the complex signals they collect to micro-segment their customer base and deliver nudges, delivers targeted intervention at the segment level. And I think a mixed approach like this based on high-resolution micro-segmentation and individual targeting is probably the way forward in reasoning about engagement and reasoning about attrition in using wearable devices as well.
Yeah, and just to add to that, some of the research that I've seen, limited research from an insurance company that looked at it, that provided devices out to their membership, was that after 1 year they received double the amount of people that would have been expected to have continued using the devices were still using it, because they provided the positive feedback and reason to be able to use those devices. I think a second piece of this that a number of the speakers have already hinted at is the ownership of the data, ownership of your own data, personalizing it. I mean, to make a very specific point on that, Financial Times reported that an individual who has high blood pressure or cholesterol, that record in a marketing firm is worth 26 cents on the dollar. For somebody who's exercising and trying to lose weight, that record's worth 10 cents. So there is a very finite and precise value that's assigned to this type of information by marketing companies, and I'm sure insurance companies have the same feeling as well. What I'd like to do is, and starting with Elad, is ask the question, how can individuals really harness their own data, either for incentive reasons, personal incentive reasons, or for valuation reasons?
So I think that's a hard one right now, because we don't really have enough examples, perhaps Peter does have, of places where just the individual data is enough. And perhaps that's going to change, but I think it's still early days for that.
I think you touch a very complex issue there, and I agree with you. There's a Swiss professor right now. He's trying to build a cooperative. He's a very famous Swiss professor called Ernst Hafen. And he says, you give your data, and you know your data will get used for everything. So he goes the opposite way, and I just want to take both sides of it. So he's professor at ETH in Zurich, which is where Einstein did his PhD. And he was used to be the president, and his specialty is antibody research. And he came up with this idea that I make a cooperative, and all the cooperative members, they sell their data to big pharma companies. And they know they sell their data, and then we share all of the income to pay for our healthcare costs afterwards. And this has created, I wouldn't call it a civil war in Switzerland, but very interesting discussions. And like you say, is my data alone good enough to prevent a disease? I'm honest, I don't think so. So this something for something economy, I believe, is very, very important. I just want to jump completely in the other direction. So I was really astonished, and again, I've been in this industry for 30 years, when people went banana about the whole, Facebook sharing data with the NSA and so on. And I was like, it's funny, because last year, 2013, the data center of Facebook costed $4.2 billion just to operate it. And how can people, and I really provoke again, and I like to provoke, be so stupid to think I put all my data in there, they store my data, thousands of pictures free of charge, they spend $4.2 billion, and they don't use it for anything. I don't know in your countries if the Christmas man is still, coming down, flying up from Greenland, but where we live in Switzerland, that doesn't work. And I'm extra provoking. So I think the reason why the internet became so successful was because governments did not get involved. Digital healthcare is making me very nervous right now, because all governments want to regulate and everything. So that would actually make people die. And again, I provoke, because a lot of things that could prevent diseases would be forbidden. And that's why I'm taking the other side and saying, I want to be God, of good privacy, good behavior. And I think in any healthcare data, there should come up, opt in, opt out, where it specifically says, big box, big letters, if I do this, this happens. I mean, on Fitbit, it is written with so small letters that I guarantee you anyone above 50 cannot read it. And then it just says accept. I mean, you have no idea what you just accepted. And so both sides, I think, are very, very important. But if the government forbids everything, you will have many million people dying that wouldn't have needed to die.
Yeah, I agree with that completely. I think people should have the option to have complete ownership of the data and zero sharing whatsoever. But I think you need to educate them the benefit of population level analysis and how you could better predictive analytics could be derived with this contribution of data. So it's about giving people the choice, but also educating them very clearly on the benefits of sharing their data.
Hi, Nico Preston, Health Map. Question to follow up on Clark's question, and that's a what next element, and that's around the persistence of your data. So you've had your Fitbit for 6 months, and you lose interest. I think with all the new options out there, people are jumping around trying different things. How do you keep a continuous record of a person's health? Where do we store and persist it? And is it an individual's responsibility to sort of carry a thumb drive through life or a Betamax cassette to keep a record of their data? So how do you persist this health data?
So Peter, you talked a little bit about some of the government solutions in Europe on that. Do you want to start?
We basically normalized the data. And I just want to say, if you take a Fitbit, a Jawbone, a Microsoft, a Google Watch, and I did the exercise, and you put 4 on your hand, and you walk for 5 kilometers, you get a variation of 40% difference, okay? So I cannot license that to an insurance company because, there's 40% default risk built in. What we do at Cattuto is we do something that we call MET models. So we actually did the cumbersome exercise of putting heart monitoring on people. So we measured 115 different activity styles. MET stands for metabolic equivalent of a task. So it's how many heartbeats do I have to do 1 hour of gardening work? How many heartbeats do I have to do to swim 1 kilometer of crawl swimming? So to answer your question, number one, we normalize the data. We set score the data. So you compare apples with apples and not apples with banana. And the second issue is that we work with timelines. So we create and compute statistical models of if you were used to do this, and like you said before, if we then can have driven you off to a good direction. I mean, my CTO, when we started 5 years ago, he has lost 85 pounds. Digital everything. He's lowered his blood pressure with 25%. So we see that it works. And he started with a Fitbit and all that he's thrown away. He doesn't use it anymore. But we put him off to the right, like you said. And I think that's very important. You can compute behavior. You can normalize data. And then you have, I think, 85, as I said before, to 95% correct outcome.
I think one of the problems is how do you define health data? So if it's clinical records, most countries will save them forever. But if you think about something like a search engine log, which we know contains a lot of health data, by law that cannot be saved for more than 18 months in the EU. So there's a regulation called A29 which prevents that data from being stored. And so if you think about that as health data, right now we cannot store it, and we don't really provide an individual the tool to save it for themselves. And so I think it's one of these areas where we're still unclear on who owns the data that you want to save for longer, because if you're saying that the company owns it, then we're not allowed to store it any longer. So it's a problem right now.
I think we should start a broad discussion at the regulatory and legislative level towards the idea that the data about your person, data about your body, belong to you as a citizen. I think you're just, in the long run, we'll need to have a framework in place by which you license a third party to use your data. I don't think that private ownership by the service provider, by a device provider of your health data is really a viable solution in the long run. I think it's a recipe for disaster. So I do have a pretty radical opinion that the data belong to the person, and the person should have the freedom to revoke. You, even as a device owner, even as the company processing the data, an individual should be able to revoke the right to access those data. So there is a movement, especially in the web science community, about defining open standards for personal data stores that allow you to create systems that are decentralized. It's sort of a long-term vision of a web-like system, which is fully decentralized, which nobody controls from a single endpoint, where you have control of your own data and you license access to this data to a third party, both for reading and for writing to the data store. And this is, of course, something which will, whether this is achievable or not, it depends on a number of boundary conditions, on market, on regulators, on the big players shaping this market. So this is really a far shot. But I really do believe that in the end, the only viable solution is that we enforce the ownership of the individual of his own of her own personal data.
All right, so far we've identified two opportunities for innovation here. One is to be able to allow the individual to own the data, and the other is to store it. Do we have another question?
Thank you. Sam Scarpino from the Santa Fe Institute. I'd be curious to hear your opinion, given the focus on disease, about removing the public from public health. So what happens if you are all successful and 99% of the health data is owned by a handful of private companies and no longer by global or national agencies?
Besides nods, do we have takers on that question?
Since I got the mic. No, I think that goes along the lines of the point I was making. I think that you have to guarantee ways of maintaining the public into public health, and this is challenging path to design if you allow a host of personal health related data to be stored and processed and owned by private companies, by industries. I don't think that's a way forward. I think we need better groundwork, both from the ethical perspective. I see Effie Vallena standing there, and from a legislative perspective, to actually help us unleash the power that we all recognize is in wearable and wearable powered public health, without actually impairing fundamental rights. So we need to really reason more about what these fundamental rights are and how they relate to your personal data. And I think this is just getting started.
I think what you address is a very important issue, but if you think about it, the big players already have that data, and you are naive if you think they don't. So Google, Apple, Samsung, Microsoft, they are all building their data cylinders. The EMR companies, I mean, Epic has, I think, 72% of all Americans' data stored. So it's naive to think it's not taking place. And I don't think you can stop it, because that's the power of a free economy. I think what is a lot more important is, what do we do with that data, and that we inform the consumer about who has your data. And that is today not the case. And I think personal health care data should be stored with a unique identifier, meaning I can always follow my health, my objects, and as I said before, I opt in to approve. I just want to turn it completely upside down as well. I was invited to give a speech in Singapore at the Asian Data Convention, and I spoke about data security. And after my speech was the health minister of India. And then he came up and he said, it's all good what Peter is saying, but it's completely ridiculous. And then he said, in my country, I have 100,000 patients on 4 doctors. In France, they have 1,000 patients, and they have, I think he said, 4.7 doctors. In India, we have 0 data security. We don't want to have data security, because people will die in our hospitals if we would start making systems like this. So we are a little bit back to, my data is my data. And if we just go back to our kids' generation, they share everything on the net. And I fear, I'm just saying, that we are the last generation where my personal healthcare data is so important, the other day we had a discussion at home, and our daughters were like, "Oh, we know this guy. He's fat. We know that she's depressive." You know, they were talking about all our friends, and they were just looking at what they look like. So they're like, "Why should that be secret?" And I'm just saying, so the digital economy that comes after us, that would never go into a bank, that would never wear a credit card, that would pay everything over the Apple Watch, etc. It's going to be highly disruptive. And sometimes it looks to me a bit like we are holding on to something that won't even exist anymore.
Thank you. And to add on to Sam's question, or take it in a slightly different direction with one of my own, I'll turn to Jared first to talk about this. We've talked a lot about how wearables can be useful for chronic conditions, but it's also useful for emerging disease and detection issues as well. And so can the panel talk to how wearables can be used in those situations?
Sure. So, specifically for again the temperature monitoring that we've worked quite a bit on, I think it's really useful in monitoring. So, for example, for Ebola, for the Ebola outbreak, for early detection in healthcare workers. So, both in healthcare workers who are returning from infected areas, as well as healthcare workers who are working with patients who are already sick. Collecting this information in real time would be really useful in terms of a kind of a first signal that something might be wrong. Yeah, that's just one example, I think, where having this data stream, when you know what symptoms to look for, can be really helpful.
So I'm not entirely convinced. Google Flu Trends hasn't been mentioned yet, but supposing that we can predict ahead of time, a few days ahead of time, how many flu patients hospitals will see in a given geography, how important is that actually? I mean, you can open a few more wards, that's important, but I'm not entirely convinced of the how important that is. Perhaps for something more targeted like healthcare workers in Ebola, that's pretty important. But I think we need more examples of those cases where you won't get the health authorities to see them within, to detect them within a day or two, and that's all the lead time you're giving, versus something where you're actually being able to say there's going to be a significant outbreak that we wouldn't figure out with other tools, and we can do that with wearables. I don't think we've seen enough examples of that.
I was just going to say, and what about hospital-acquired infections? Would you add?
So again, wouldn't you be able to get a better signal if you ask hospital staff to inform people that they should be aware of that and carefully monitor their own devices, rather than have some system that would monitor these people specifically? I think you would probably get a better outcome if you just inform people that they should be on the lookout for this and use that.
At the same time, probably we will see a lot of wearables making their way into devices and personal devices in hospitals. And if you integrate these signals over a long enough span of time, you'll be able to cross-mine this data with data on hospital-acquired infections, and at least statistically aim at understanding what are the risk pathways, what are the risk factors, what are the determinants of transmissions for hospital-acquired infection. And so probably this can drive better tailored intervention, or this can drive experimentation where you change something in a hospital and then try to see how that relates to your outcome with respect to the interaction metrics that you measure.
Question from the audience?
Esha Vayana from the University of Zurich. I'm sorry, I have to backtrack a little bit and go back to the previous point. I didn't get to ask my question then, or actually a comment. I think getting the public out of public health point is very critical, very important. And I think just by saying that we just inform the consumers that their data are somewhere, somebody has it, and they just know it, I don't think that's enough. There is probably more to do with that if we agree that citizens should have control of their data. They might have more control over secondary use of the data. And a correction here, you misrepresented the cooperative initiative in Zurich. You said that the cooperative initiative is about people selling their data. It is not about selling their data. It's about pulling their data together, putting their data in that sort of system that they can be accessed and they can have control over the uses. So the idea is if you have your data somewhere and that company has it, you have access to a copy. And you can get the copy, deposit it in that pool, and have different sort of uses. So at least you get control of secondary uses. And this control can be managed differently. So the point I'm trying to say is that we can't afford having that closed somewhere and just be satisfied because we told the consumer. I think that's insufficient. So we need to be more imaginative about what it can be done and what kind of control, more meaningful control citizens can have. And I think that applies in data that are already in corporations, data that we're going to be having, wearables, and all sorts of things. So it's more of a comment and just a correction to the point that Peter made earlier. Thank you.
I appreciate the point, and I think everyone agrees that it is a balance here that's to be struck between allowing individuals to have control of their data and still being able to meet the population and public health demands for that data at the same time. So it may be a user-based question, it may be an end provider-based question. Do we have additional questions from the audience or additional points that the panel wants to make before we wrap up here?
So it is a conference on diseases. I think location is very important. And what I've been working on the last few years is find a way to do local disease detection at very low cost. So what we have invented, and it's a technology where you take a litmus paper, just like a pregnancy test. So you take this litmus paper, you add a color sequencing technology on it, so it kind of changes color. You put the blood sample on the paper, or you put urine or saliva, and then it changes color, and you just take a picture with your smartphone, and it sends it off to an indication server that will see these color changes and will identify early detection of malaria, early detection of AIDS, etc. And this we have patented, and we think that the cost is going to be less than $2 for doing this kind of test. And we believe, I mean, we've not done the product yet or anything, I'm just saying, we believe that that will be very powerful, because if you combine that with the GPS data of the smartphone, you will have large majority detection of local data, what is happening in this part of the world, and you get the data, and you can help prevent this. So I think, again, nano sampling of blood, saliva, and you combine that with GPS, with a smartphone, can do huge things in the low cost of the market.
One thing we didn't really touch on that much, and I guess is also relevant to your last question on emerging disease, is the use of wearables for outpatient and telemedicine. I think that's an area where you're not in the hospital, you don't have better devices and trained professionals right there to take these measurements. So I think that's an area where there's a tremendous value in collecting this information and transmitting it to, so for outpatients, collecting information, transmitting it back to clinicians, and same for telemedicine, kind of remote monitoring. I think will be, more immediate value in this type of technology.
So coming back to the last question or comment, I think the question of privacy and ethics is something that, as a community, we're still struggling with. And if you've been to the conference next door yesterday, you would have heard a very interesting discussion about this question of what is ethically possible and how do we grapple with the question of privacy. I mean, you could easily, if you recall the outcry that was very visible with the Facebook study a few months ago. I mean, to somebody who comes from the industry that's used to doing what we call A/B tests on a daily basis, that was a pretty benign kind of study, and yet it rattled a lot of people because they didn't realize that this is something that was done. And so I think we need to work much better first at informing people, but also informing them of the benefit. So yeah, you could creep out people very easily by saying, we know where you are and what you're searching for. But if you say, but we can use that in order to predict if you're going to have a manic episode, well, maybe that's something that you're willing to live with. But we have to ask you whether that's true or not. And so this question of ethics needs to be understood better as we do more work in the space of the disease detection.
I have a, just a follow-up. If somebody has cancer or they know they're dying, and we have seen this with our system, they are willing to share any data. So it's very, very interesting what you were saying there. In a normal life condition, you want privacy and so on. If you know that it can enhance your life, you will give all data to anyone you ever met just to survive. It's just a
But even more than that, I think many people, if you tell them you can benefit other people by giving some of your data for this use, many people will be quite happy to do so if you don't identify them individually. And a lot of the work that we do is actually looking at populations rather than individuals. And yet, I still think we need to be very clear that that's what we're doing so that people can opt out if they don't want to participate in that kind of a public exercise.
All right, I want to thank all of our panelists for being up here and taking questions, and